Okay, let's do this. First test, not going to be an abdomen. It's going to be a thorax. We got this from a doc. I'm not sure what the history is, but she will notice the study and she can feel free to tell us. So what we're going to do, same thing, like the same format, which I think it's beneficial. Again, I can't say this enough. So it's one thing if I just put together a video and I say, this is pneumonia, and I say, this is heart failure, and then you sort of passively ingest it. I think it's another thing to form an opinion in your mind during the pause. Ideally, you write it in the comments because it forces you to put yourself out there. You commit, and then I tell you what I think, and then we sort of decide, do you have any questions? Do you think you're right or wrong? And it's, I think, akin to learning a musical instrument and having somebody tell you your note's right, your note's wrong. And I think getting that immediate feedback is a completely different thing than just trying to learn by yourself. So, okay, so this case, this is almost a 12-year-old lab with complaints of polydipsia, CBC Chem, T4, UA, culture. It's all normal, urine-specific gravity 1014. Okay, so I've also noticed, and you guys can tell me if you're noticing this as well. If I'm quickly rotating through radiographs, there's a blur. So it's almost like I have to pause to let the upload speed or the technology catch up. So I'm going to try to not flip through these as much as possible. So I'm going to do 1 minute. Again, tell me feedback, too slow, not enough, need more time. Okay, 3 views of the thorax. I'm going to show you just right lateral, left lateral, and a VD view. Okay, so 1 minute, go for it. Tell me if you find anything that's wrong. Okay, and then because I had all this downtime, I created these cute little banners. So these banners, this is the Röntgen sign. So we will use these to describe things. And I would encourage you to practice using these, because I think if you get into the habit of describing things, it will help you in cases where you're not necessarily sure what's going on. So do the Röntgen signs help you when you know that it's pneumonia or heart failure? Yes and no. I mean, when you look at it, you just kind of know after a while that this is pneumonia, this is heart failure. But when you have other things that are kind of odd looking, when you use the Röntgen signs, they can kind of help you narrow things down. So anybody see anything? Yeah. So I think everybody's kind of seeing what I'm seeing. So I'll tell you. I'll just tell you how I went through this study. So the doc that had a question, I think one of the things that's an issue for this particular patient is you can see it's an obese patient. There's a lot of fat, and so you can get these fatty lipomas, and they can, fatty lipoma. That's redundant. You can have a lipoma, and it can be superimposed with the chest, and it can create a bit of trouble for you. So one of the things, don't forget, is you can put barium. Just if you feel a palpable mass, put barium on the patient, take orthogonal views, or VD and a lateral view, or DV and a lateral view. That can sort of help you in hospital determine if something's extra thoracic. But yeah, so there's a soft tissue opaque or an opaque structure in the cranioventral thorax. But what I do is first I look at the cardiac silhouette. So this cardiac silhouette is normal. Okay. The left atrium would kind of come up here and it would straighten. The thoracic trachea would deviate toward the thoracic spine if we were worried about left ventricular enlargement. So there's no loss of caudal waist. There's no increased opacity here. There's no 2 to 3 o'clock left auricular bulge. This is fine. So sometimes you'll think that you have loss of waist, but the pulmonary veins, when they come into the left atrium, they can give this sort of flamboyant caudal waist. And so it's actually accentuated, not lost. So no left-sided cardiomegaly. It's not too wide. There's no increase in sternal contact. There's no sort of reverse D rounding, and it still has its shape. So because it still has its shape, you really are not thinking pericardial effusion. The caveat to pericardial effusion is it depends on the volume and the time. So if you have an acute, and I'm kind of going on a tangent here, but if you have an acute accumulation of pericardial effusion, there was a study done out of Montreal that said that the globoid shape that we always sort of classically think is related to pericardial effusion, that's for patients that have a decent amount of fluid that's accumulated over a period of time. So if you have a relatively rapid accumulation of fluid, the cardiac silhouette actually cannot it won't give you that globoid shape because there hasn't been enough time for the pericardium to stretch. And they were finding clinically relevant cases of cardiac tamponade in patients that lacked the globoid shape. So don't always say, "Oh, there's no globoid shape, so there's no pericardial effusion." That's not going to work. Okay, so cardiac silhouette's fine. The pulmonary blood vessels are fine. The trachea is fine. And by fine, I say normal. I say normal or abnormal. And I keep the sentences structures very simple. So the trachea is normal. You could say it's normal in luminal diameter and course. So the cranial mediastinum, I usually describe as being within limits because it's a confined space. And so when you use these Röntgen signs, what you want to do, I always like to start with the location. Because if you were to close your eyes and I was to describe something, you want to be able to form a picture and in your mind. And it's, I think, very helpful to describe the location first, because then you go, okay, this is, so you could even say, if you weren't sure, you go from very general and you cone it down into more specific, if you can, localizations. And so you could say within the cranial and ventral chest, because you're like, I don't know if this is on the body wall, a rib, the mediastinum, the lung, the pleura. So you could say within the cranial and ventral chest, there is a round, opaque structure immediately cranial to the cardiac silhouette. To me, it's tough to determine if this is fat or soft tissue, but I bet it's fat. And the reason that I bet it's fat is because this is mediastinal fat. And I don't know, it looks a little bit more opaque. So it's probably soft tissue. The caveat to that is if you have really dense fat, it just will attenuate more X-ray beam. It can actually look a bit soft tissue. This is all, this is fat down here with lung overlying it. So within the cranial and ventral thorax, there's a round soft tissue structure. I don't see it on the VD view necessarily. It's probably hiding right here, but it's certainly not over here, and it's certainly not over here. So within the cranial ventral thorax, and then you could say, based on your comfort level, you could say the cranial mediastinum has an opaque mass. If it was more than 3 centimeters, you could say mass. This is smoothly margined. You can see sort of clear borders. You could drop calipers on it to get a size. But excuse me, to take it a step further, you're going to want to decide, is this a craniomediastinal mass or is this sternal lymphadenopathy? So the sternal lymph nodes tend to be broadly based and they kind of come up like that. So this thing has got a round border. You can't see it as well here, to be fair. It's here, but it's less obvious. So round structure here, you can see the line going under it. So it's not broadly based at the 2nd/3rd sternobra like you'd expect a sternal lymph node. That's important because if you thought this was a sternal lymph node, you'd be checking the body wall and be doing abdominal ultrasounds or abdominal imaging. So there's a craniomediastinal mass. And then the differentials, they should just sort of roll off the tongue because it's the same ones. It's hard to tell the difference. But I think one of the important ones not to forget is a cyst, a bronchial with an a bronchial cyst. And so you could pop an ultrasound probe up there if you can make it through all the fat and the patient holds still, and you will see something that really looks like a urinary bladder. Other things to consider are thymoma. Thymomas have a cystic component. And so when you put the ultrasound probe on there, don't just say, oh, I see fluid. Ultrasound probe goes up, look for a urinary bladder. If this thing looks like it's got some tissue to it and some cysts or cavitation, it could be a thymoma. You could have thymic lymphoma. You could have ectopic thyroid neoplasia. And then other things that are less common are like, you could, again, we talked about this, I think, last time, Chang or cyst, hematoma, abscess, neoplasm, granuloma. So you could Chang it. But I think the importances for this one are that it's in the cranial mediastinum, that it's not a sternal lymph node, and that you also don't see megaesophagus and aspiration pneumonia like a thymoma would potentially cause myasthenia gravis. So that is that. And there is some spondylosis, doc, but I don't know if I care about that. I mean, I know that we're supposed to talk about that, and I think a lot of veterinarians like us to talk about this because then they believe that I've looked at the study, but when there's this huge need for images to be read out and so on, sometimes what I'll do is I'll describe it, but I won't conclude in the report. Okay. So I say cardiac silhouette, and then I go pulmonary blood vessels. Then I say that the trachea is normal in luminal diameter and course. Then I talk about the cranial mediastinum. And in this particular case, when I flip the dog over, here's the cranial mediastinum, and it's a little too wide. Then I talk about the pleural space. So I kind of go down here, I go boom around here, boom, boom, boom. And then I kind of do it bit by bit. I look down here. The fact that you can see these margins tells you there is no pleural fluid. Sometimes you'll see rounding up here. You'll obviously see pleural fissure lines, so we don't see any pleural fluid. Cardiac silhouette, pulmonary blood, cranial mediastinum, pleural space. And then I'll talk about thoracic lymphadenopathy. So I usually say thoracic lymphadenopathy is absent or present. So I would be less inclined to use it in this because I don't, because you got this structure. Could this be a lymph node? It's possible. It's not a sternal node. It could be a craniomediastinal lymph node, but I also often find that those are kind of up through this area. But the tracheobronchial node. So when the trachea comes down right here and you've got the carina, the tracheobronchial node, you'll have a vague opacity here and it kind of pushes down. So there's no, and so the trachea comes down here, and then the tracheobronchial lymph node would push down here, and you'd have sort of this cowgirl sign right here that it mimics left atrial enlargement. So there's no thoracic lymphadenopathy. So Dr. Allen wants to know, so the mass isn't soft tissue fluid opacity. So I think it is soft tissue fluid. And the reason that I think it's soft tissue, I think when you look at this, you may say it could be fat because it just doesn't look really opaque. But then one of the things that you want to do is you can use internal controls to decide, do I think this is fat or soft tissue / fluid? And in this particular case, these are just to remind everybody, I like these banners. If anybody wants a slogan on a banner, just let me know. But these, I think the reason that you can see this so well is because it is soft tissue and fluid opaque. Because if we're going to say that this is in the cranial mediastinum, which we think it is, it's surrounded by fat, and so the fact that we can see it so well, I think it's because it's a different opacity from fat. And so if this was fat, I think it would be a little bit harder to tell. Sometimes you will see intrathoracic lipomas, and those are just, I feel like they're not as common, but they're less opaque than this. And plus, you could also sort of say, like, well, here's the cardiac silhouette, and we know that that's fluid / soft tissue opaque. It has lung overlying it, but we know that that's a soft tissue fluid structure. And this is kind of like that. So I think it's the reason that we can see it, because it's got fat next to it, which is different than the soft tissue / fluid. It has gas overlying it. And then we can use sort of an internal control, things that we know for sure. Bone is mineral, that marker's metal, help me. Microchip is metal. So I think it's soft tissue opaque. So the recommendation is for a CT or an ultrasound. So yeah, the easy thing to do is to say that it is to do a CT. I mean, I think it's really easy to go, hey, do a CT. And I think this would be the best thing to do is the CT, but you may not have a CT or they don't have the funds. I think you could attempt to ultrasound this. But you have to get through a decent amount of fat, which can be done, but you may have to knock the dog out because it's not a big structure. Can I outline it on the VED view? No, I can't. I think it's vaguely thickened. And the thing is you can get widening of the cranial mediastinum secondary to fat, and we do have a fairly large deposition of subcutaneous fat. But I just think that if we were going to blame this on fat, in my experience, it's usually a little bit more uniform. It's just like a little bit bulgy through here. And it usually, if it's fat, we can see some bulldog chest, but it usually is just this sort of straight shot of fat. So I don't really see it. But I also don't really see it here, and I don't really see it in the lung, and I don't really see it here, and I don't really see it there. Excuse me. So it's there. And so that has to be on a midline position. And we don't see it because there's a ton of fat that it's going through. This beam is just coming through all the way through. It's attenuated. It's probably being partially obscured by the cardiac silhouette. So I'm not surprised we can't see it. To me, this is a pretty straight radiograph. Yes, it's a little bit rotated, but I think it's darn good. So I don't have really any complaints about the positioning on any of it. I think this view's a little underexposed. You could turn it up a little bit, turn up the oven. This is a pretty good study. Nothing's washed out. I can see the mass. So this mass looks cute. I think we could all agree that it's kind of this cute looking thing. And would we be surprised if this was an incidental cyst? I just wonder. I guess I wouldn't be surprised if this was an incidental cyst. And so this would be a case where you say, hey, can we try to ultrasound it? If you kind of feel confident in doing that, and you're trying to look for something that looks like a urinary bladder. And if it looks like a urinary bladder, maybe what you do is you say, all right, let's recheck this thing in 2 months, 3 months, and see if it's grown in size radiographically. Maybe you recheck it again. But you're not wrong to CT it. And on a CT, this thing will, you'll be able to confirm its location within the mediastinum. You'll be able to confirm that it's not invasive. You'll be able to confirm that it's thin-walled and fluid-filled and there's no enhancing tissue. And so then you go, oh, I bet this is an incidental cyst, and then you can leave it alone. Maybe you recheck it later on and further down the line, but you don't go nuts and stick needles in it and stuff. There you go. All right. Sweet. So no musculoskeletal, right? Please, nobody say, let's do musculoskeletal. We could do this one. I said we were going to do abdomen. We're going to do abdomen. Don't worry. But this was a cool case. So all these cases, I just read them out today. So these are all recent cases. And then if we want, we can hop into some new cases that I haven't seen and go through those. So this is an 8-year-old dog that's presented for coughing and tachypnea. And the breed, it's a mixed breed, and we've got 3 views of the thorax. There is a right lateral view, there is a left lateral view, and there is a VD view. Okay, so let's give you some time here. Go for it. Dr. Christie. Doc Christie. And Ure thinks the dog has to pee because he's gotten LASIK. So Ure is already on his way to talking about heart failure. So, okay. First thing, we didn't really talk about it. Technique. If you guys could do me a favor, these borders, it's I don't know if it's bugging you, but what it does is it bugs me because it's like trying to view the radiograph with somebody kind of shining a light in your face. This is not bad, that one's great, but that's just an aside. So okay, first thing I start with is usually the cardiac silhouette, right? So cardiac silhouette, this patient has cardiomegaly. So if you follow first of all, it's expiratory. Right. I think we talked about the accessory lung lobe will sit in this area and it looks like a piece of pizza. And this is fairly small piece of pizza. See how this one's bigger? It's really great to compare those side by side because you go and look, once you compare these side to side, how more opaque it looks back here relative to there. And yes, some of that is from pathology in the lung, which I'll explain in a second. But a lot of this is from a lack of gas. The animal breathes in gas. It's black like my soul. It fills the lung, and that blackness allows you to then differentiate with anything that's opaque. And in this case, when you convince yourself that the dog has cardiomegaly and he's tachypnic and he's coughing and you scold the murmur and you're freaking out, and then you go, I need to know if the dog has edema or not. You want that to be really black, really radiolucent. So you want an inspiratory radiograph. Good luck trying to time that. That's really challenging. But one of the other things that you could do is a DV view. Sternum on the table, DV view. It highlights the caudal lung. One of the things, let's just talk about the cardiac silhouette, okay? So the cardiac silhouette, 9 times out of 10, you could put up the study, you don't look at it, you close your eyes, and you could go, the dog probably does not have pericardial effusion and probably does not have right-sided cardiomegaly. They're just not that common. We read thousands of radiographs every year, and just so infrequently, I feel like I'm getting confirmation from echoes or histories suggestive of pulmonary hypertension from pulmonary fibrosis or heartworm disease um, or other things like that. So usually it's a left-sided problem, okay? So what you could do is you could back into the left side by trying to rule out, confirming the probability that right-sided cardiac disease and pericardial effusion are less likely. So the first thing I'll do is I'll say, does it look like a cardiac silhouette? And in this case, it does. So it makes it less likely, not impossible, but it makes it less likely that the patient has pericardial effusion. So you go, okay, probably not pericardial effusion in this particular case. And then you go, does the dog have right-sided cardiomegaly? So the cardiac silhouette is wide, but one of the tricks that I'll show you as we go through more studies is one of the things that I've noticed, and it was reported in a thoracic book, the BSAVA. They talked about the cardiac apex on the left lateral view, and I'll be honest with you, you can't really see it in this study, and so it's not particularly helpful here, but I'll show you hopefully on some other studies. But normally, the apex of the cardiac silhouette on the left lateral view should be a little bit dorsally deviated from the sternum. But you really shouldn't see that on the right lateral view. The right lateral view, this apex should sit on the sternum. So if you're worried about right-sided cardiomegaly, look for that apex to appear to roll dorsal, and it could be kind of subtle, but you want to look on the left and the right view. And if it's on the right lateral view, it's game on. Because I'll be honest with you, you don't always get the reverse D. It just doesn't happen. And I would say in this particular case, this needs to be filled in with tissue in the area of the right ventricle, right? So you got left auricle, left atrium, left ventricle, right atrium. You got the sort of a collection of structures here. So you have the aortic arch that comes around and does this. Then you've got the 1 to 2 o'clock is the MPA, the main pulmonary artery bulge, 2 to 3 o'clock left auricle. So there's your clock face. So this 6 to 9 o'clock needs to get filled in a little bit more. But again, our ability to discern right-sided cardiomegaly, pulmonary hypertension on survey radiography like this, I think sucks. So what you're looking for on the right lateral view is normal in health dogs on the right lateral view, the cardiac apex should touch the sternum. It should be in close contact with the sternum. It should look kind of flush like this. That's normally on a right lateral view. If you see the apex of the cardiac silhouette rolling dorsal to the sternum on the right lateral view, that's not normal. And that could be a telltale sign that the dog has pulmonary hypertension. You don't use that sign in isolation, but what you do is, I think it was it Doc Curtin? Yeah, so Curtin said, I wonder if this dog has right-sided cardiomegaly, so I would suspect pulmonary hypertension. So cardiomegaly, right-sided cardiomegaly is not only uncommon, it's hard to diagnose. And so one of the subtleties that you can look for, if in this case you're Dr. Curtin, you go, I think this dog has right-sided cardiomegaly, look for that sternum and cardiac apex association. And if you see the apex rolling dorsally on the right lateral view, I think then you should sort of go game on for right-sided cardiomegaly. And maybe in a second I'll find a right-sided cardiac disease case, and you'll see what I'm talking about. So does that make sense? If you're trying to convince yourself there's right-sided cardiomegaly from pulmonary hypertension, look at that apex of the cardiac silhouette on the right lateral view. And if it's rolling away or if it's tipped up dorsally, you go, oh, maybe I'm onto something. But I'll tell you, right-sided cardiomegaly, pulmonary hypertension, it's a bitch. It sucks. It's really hard. It's easier in sort of classic cases. So cardiac state, so the enlargement on the right side of the heart means that the apex, yeah, that's correct. So the enlargement on the right side of the heart means that the apex can't get down to the sternum. It's too round. Yeah, I think there's too much tissue. It normally isn't intimately associated with that sternum. And I think the excess tissue causes it to just sit up. And I'll be able to find a case here in a second, and I can show you. But let's just say that you thought the dog did have pulmonary hypertension, because I don't want to confuse you, but one of the causes of pulmonary hypertension is post-capillary, so after the lung. So it's actually, you can get pulmonary hypertension from chronic left-sided heart disease. And so if you have mitral valve disease, which this dog has mitral valve disease, this is a big old left atrium. And this is the left atrium in here. And this is the left atrium in here. This may actually be a margin of the aortic arch, so I wouldn't use that. But this whole area right here is too opaque. So this dog definitely has left-sided cardiac disease. If the cardiac disease is severe and chronic, it can actually result in increased filling pressures in the lungs, right? As the pulmonary veins dump blood into the left side of the heart, that pressure is it's a closed system, so it will just continually back up. And it backs up through from the enlarged left atrium, pulmonic veins, then the pulmonary capillaries, and then you've got the right side of the heart, the pulmonary artery is trying to jam blood into that congested system, and you will get pulmonary hypertension that oftentimes I think can be improved with improvement of the left side filling pressures. So, but let's just say Dr. Curtin was like, I think this dog has right-sided cardiac disease as well. I think you could describe this as moderate to severe generalized, but predominantly left-sided cardiomegaly. So that's what I would say. Moderate to severe generalized, meaning right and left, not globoid, right and left. And sometimes I'll say in my report, moderate to severe generalized open paren right/left closed paren cardiomegaly, or right/left, but predominantly left-sided cardiomegaly. And then the next thing out of your mouth should be, is there cardiogenic pulmonary edema or not? So do people think that this dog has cardiogenic pulmonary edema or not? It does. It does. Yeah, it does. Okay. So for those of you that are coming back and have heard me talk about this. No, Doc Christie, you were absolutely right. Well, so let's make sure what you're looking at. So what I thought looked like pulmonary edema at the heart base was only the enlarged left atrium. Well, let's see if this is what you were looking at. So I'll show you the left atrium. This structure right here is the left atrium. See how you can see almost like a butt on it? So this whole thing is left atrium. I'm not going to pretend like I can see. I mean, I know there's a rib right here, but it comes around here and it just kind of goes up, and I kind of lose it, but it's probably under this rib, and then it goes like that. So that's the enlarged left atrium. On this view, it's hiding over here. This whole thing right here is left atrium. Okay, so that's this structure right here. But what you should do is you should go, well, what in the world is all this? That's really opaque. And then you go, well, wait a minute. Okay, if that opacity, maybe that's just expiratory phase of respiration. That bullshit that radiologists put in there to not be helpful. But it's real, because look at this dog. This view is taking a really good breath. This piece of pizza, this is your piece of pie right here. It's pretty big. This one, this down here is very small. But let's just say you think this is expiratory phase of respiration, because this view is, I'm going to be honest with you, it's a little more normal. I don't think it's completely normal, but it's more normal looking lung than this. But what you do is then you flip this dog on its back, right? You remove these little things, you flip the dog on your back, and you go, the lungs look abnormal in the caudal lung lobes. And then hopefully you can see this right here. This is just too opaque right here. Less so over here, but it's too opaque right here. If you weren't convinced on this, you take a DV view. Sternum on the table, X-ray beam comes in, and what that does is that highlights this area really well. Okay, so when you highlight that when you pull in that gas, it's going to allow you to discern with a little bit of faint edema, which is opaque. Okay, so this is the big left atrium. This is the big left atrium, but this is edema. That is edema that doesn't look as bad because the dog's taking a good breath and he's pulling in a lot of black, a lot of radiolucent air. Okay, flip the dog on its back. Here you go. So moderate to severe, generalized but predominantly left-sided cardiomegaly with cardiogenic pulmonary edema / heart failure. mitral valve, tricuspid valve endocardiosis. Maybe we've got postcapillary pulmonary hypertension. But my buddy Graeme, the Scotsman, where did he go? Distal trachea tapers oddly. Yeah, I like it. It does. It's weird. If things look weird, man, if you see something, say something. I think that's what you're supposed to say. So distal trachea tapers oddly. It does. So when this trachea or the trachea comes down, look at this view. So if you got that view, we're going to do the right lateral here. And so this view, the trachea comes down like this, and you can see right here, you can kind of see where it branches. Okay. It's just, it looks more radiolucent, more gas filled here. But then when you look over here, you're just like, wait, what's going on here? Okay. So what's going on there? So this is bronchial collapse. So this dog's bronchi are completely smashed, the principal bronchi. So yeah, it's compression. So we can talk about this. Could it be compression from the enlarged left atrium? Sure, it's pushing up. It's pushing up. But what I find interesting is it's fairly severe here. One of the caveats to trying to raise concern for bronchial collapse on a radiograph is you have to be sure. One, you have to be really careful to diagnose it because it's more of a fluoroscopic thing. But you want to make sure that the patient is not rotated. When they rotate because they're trying to die and they're tachypnic, you have all this superimposed soft tissue and it'll look like there's bronchial collapse. But this is pretty good technique. And these rads right here, you want to look for these rib heads, these opposing rib heads to be fairly symmetric, and they are. So this is a fairly well-positioned radiograph. So this is collapsed. So this collapse could be from left atrial compression or impingement, because the left atrium is so enlarged. But what I find to be interesting is that it's dynamic. And so I wonder, because he's breathing in here, so it's opened up, and he's breathing out here, so it's closed down. So it's acting like a tracheal collapse. If you have intrathoracic tracheal collapse, when you breathe out, it collapses it down, and vice versa. So the dynamic change in the principal bronchi width, to me, it raises concern for chondromalacia or bronchomalacia, in addition to compression or impingement from the enlarged left atrium. And one of the things that you can do if you don't have fluoro, which most of us don't, and you're worried about tracheal collapse or you're worried about bronchial collapse, is you could attempt to do just this. You try to acquire, it's hard, and you're going to piss off your techs, but you could attempt to get a patient to be really inspiratory, a nice inspiratory radiograph, and then you turn around, you try to get them to be really expiratory. So that changes in inspiration versus expiration, and the dynamic change in pressure may allow you to see changes in diameter of these cartilaginous structures, such as the trachea and the bronchi. So moderate to severe, generalized, predominantly left-sided cardiomegaly with cardiogenic pulmonary edema / heart failure, dynamic principal bronchus collapse, consider ruling down bronchomalacia. Wow, we jammed on this case for so long. So long. Do you see pulmonary venous congestion? I don't. I don't see pulmonary venous congestion, and I don't think I would bet we don't have techs but nurses. Good. Nurses. Well, don't torture the nurses, but you could try to get the nurses to maybe hold the dog's nose and make the dog kind of upset. Hold the dog's nose when you try to take the radiographs. That could allow them to then you remove your hands and then they try to draw a breath in, because I feel like it's harder to get an inspiratory breath. Pulmonary venous congestion. I think that you got to be careful with that. We've talked about this before, but dogs that you sometimes on your end, it may be on your end, meaning in you're seeing the patient and they're in your clinic and you're understanding what medications they've been given. You'll have a little bit more of a better understanding. In the teleradiology sector, it can be hard to get great histories, and so it's possible that this patient has been given Lasix. Urate has sort of alluded to a very large urinary bladder. That's not a direct way to but it's maybe an indirect way to infer the dog's been given Lasix, or maybe he's just trying to die in his cage and he can't get outside to leave oxygen to urinate. But I would say some of these animals have been given Lasix, and that'll make those vessels kind of decrease in size because these vessels are skimpy. So I wouldn't bank on that. If you have them, great. If you don't, I wouldn't say, oh, well, then it can't be heart failure. And the other thing that we talked about, for those of you that are kind of new, everybody else maybe hear me talk about this. If you decide that you've convinced yourself that the lung pattern is abnormal, you could draw a line through the cardiac silhouette like this and then decide, is it worse cranial and ventral or caudal and dorsal? It can be everywhere, but if it's worse caudally and dorsally, your two big rule outs are, is it cardiogenic or is it non-cardiogenic pulmonary edema? And more often than not, it's cardiogenic, just playing the odds. But the minute that you have any suspicion of cardiac disease, whether that's from cardiomegaly or whether that's from an auscultable murmur, then you should go for cardiogenic pulmonary edema. Here we go. Let's see. I'm going to get an abdomen here. 1, 2, 3, 4, 5, 6. Okay. This is a 4-year-old mixed breed male that has been vomiting for 24 hours. 1, 2, 3, 4, 5, 6. There are 6 abdominal radiographs that your nurses have taken that the dog has allowed. Let's give you a minute. Here we go. I remember starting out, it was always annoying when they split them up. Stressed me out, but you kind of get used to it for some of these larger breed dogs. But this is probably a good view because it's got most of the abdomen. Yeah, so Angela, I think you're maybe referencing one of the things that I talked about, the acuteness of it. One of the things that the feces, you want it to be, yes, there's fecal matter here in the colon and sort of colorectal junction. But I think if the feces is very clearly formed and sort of more normal looking, you can sort of try to infer that it's more of an acute process. This is a little harder to do that because it looks like the feces is starting to be harder. Sort of, I would describe this as incompletely formed or partially formed. Yeah. So they took this radiograph because they want to make sure that the dog doesn't have an obstruction. So I don't see anybody that's kind of worrying that the animal has a GI obstruction. And so going through, I'll just give you sort of what I do to go through the rad. I approach the caudal thorax first, make sure we're not going to miss pneumonia. You're more likely to see that probably on one of these left lateral views where you can cheat, get a little bit over here. So left lateral view, right lateral view, VD view even. Look in here, you'll see things. So caudal thorax, and I'll just describe it as normal. The liver. So one of the things that right after you sort of look at the liver is you start looking at the stomach. Okay, so the stomach is right in here. So there's gas. Okay, so there's the gastric axis right here. And then when you flip the dog over, this is the gastric axis here. Okay, so the stomach is mildly fluid filled. So fundus, body, pylorus. Left lateral view. Great example of how on the left lateral view, the gas should distribute at least to the fundus, to the pylorus. Not always, but it should. And on the right lateral view, it usually doesn't. The gastric axis we describe as an indirect inference to the adequate or objective size of the liver. So we'd like it to be parallel to a rib or perpendicular to the vertebral column. So the liver is kind of skimpy in this particular dog, and so you wouldn't be wrong to say, hey, this could. The wording on this would be, unfortunately, this could be a normal variant. I have noticed that sort of anecdotally, pit bulls tend to have smaller livers in health, but you could raise a flag like maybe this liver is kind of skimpy. And the differential diagnosis for that in this particular dog could be a normal variant. Depending on the breed, I forget the breed, but it could be a breed-related variant. Then you could talk about, depending on the age, again, on the breed, you could talk about chronic hepatitis or a vascular anomaly, which could be a portosystemic shunt, a macroscopic portosystemic shunt, or an example of microvascular dysplasia would be more of a microscopic portosystemic shunt. So there's the liver. Here's the spleen. So I do the GI tract last because that's usually what people want to know, and so I go through and make sure I'm not going to miss anything of importance outside the GI tract. So there's the spleen. Here's the left kidney, splenic tail, left kidney. Where's that right kidney? It's in here somewhere. I don't really see it. And would I be surprised if it's normal and hiding under here and just obscured by the gut? I think that's a good, there's a likely chance. It's probably right here, caudal border, but I'm not going to lie to you and say that, oh, I see it clearly. The cranial border is often effaced by the caudate process of the caudate lobe because there's both soft tissue, you lose the border. So liver, kind of skimpy, a little bit small. Spleen is normal. The kidneys, the left kidney's normal. The right kidney is probably normal. This is no calculi that I see here. That's a nipple. Here's the urinary bladder. I describe this as urinary bladder small and fluid opaque. Left kidney is normal. Abdominal serosal detail is normal. Then I talk about the colon. So the colon has a mixture. It's moderately distended with a combination of amorphous or incompletely formed feces, fluid and gas. So we talked about anything in this plane on a dog that's not that rotated. Anything in this plane should be considered, suspicious for colon. So all this in here, colon. The cecum, gas filled in the dog, not usually gas filled in a cat. L25, 7, 6, 5, 4, 3, 2, 2, 5, right of midline. So cecum is gas, maybe a little bit of fluid. The ascending colon is probably fluid filled, transverse fluid and gas. Descending, I kind of lose it. Maybe it does this. Okay, but so then the rest of this is small intestine. Small intestine we describe as coarse, size, coarse, and content. So the size, does everybody look the same? And is everybody normal in size? So I think all of these loops look fairly similar. Some are gas filled. This one probably has a little bit of fluid that makes you think that the wall is thick. Coarse, nobody's plicated, nobody's corrugated. Everybody looks the same size. And then content, mostly stippled gas and some fluid and empty. So you look at the stomach's got a little bit of gas. This is the pylorus comes around like this, and then this is the duodenum right here. And then I lose it. Okay. So negative for a GI obstruction, probably gastroenteritis or gastroenterocolitis. Could be dietary intolerance, indiscretion, toxic, infectious / parasitic. Could be primary inflammatory, like inflammatory bowel disease, depending on chronicity. It could be Addison's disease. Sure, it could be pancreatitis, but I don't really have any support on this test, though these tests can be insensitive. I wouldn't call loss of serosal detail on a VD view because it always looks like it's got a loss of serosal detail on a big dog abdomen on the VD view. So that's it. This particular case, I feel very strongly that this dog does not have a GI obstruction. So I don't think there's any need to do follow-up imaging. I'm really bad. I look at a comment and then my train of thought just goes. This particular case, I would not do follow-up imaging unless the dog was not better in 24 hours after starting supportive care. So I don't think you need to do a repeat RAD. I don't think you need to do an ultrasound now. I just think that if this dog got into something that it shouldn't, or it's got some gastroenterocolitis, I would say that that you could only do repeat imaging if it's not better in 24 hours. How long does it take for food to get from the stomach to the rectum on average? It can depend on several things: the type of food, the consistency of the food, the size of the food, the health of the patient, the stressed status of the patient. There are a lot of different things. But if you take, they did barium GI studies, and within 4 to 6 hours, so you dump a bunch of, you do an appropriate barium study, you dump barium into the stomach. Within 4 to 6 hours, nearly the entire stomach should be empty. And at the same time, you should be seeing barium entering the colon. Hopefully that's helpful. But it's tough because you hospitalize the dog. He's stressed out. He's maybe got abdominal pain. The dog's barking next to him. He's strange poking and prodding. I mean, he's stressed. He's completely stressed out. His GI tract's going to slow to a halt, and so then you got to be careful. So I like to say, 8 hours. You want to start seeing some reduction in gastric content. Would referring to this as ileus be wrong? So when I think of ileus, I think of either a functional or a mechanical ileus. And so I think, because I think that the radiograph report, all it is just it's trying to be a clear and helpful communication device, that I try to make it as clear as possible. And so I want to make sure that none of the wording that I use is, I don't want you guys to call me. Don't call me. Don't email me, because no, I'm kidding. So referring to this as ileus, I don't use the word ileus ever. I think you could use the word ileus. You can't use the word mechanical ileus in this particular case. You could use a functional ileus, but I think that's, I think the problem with that is functional ileus to me means that the peristalsis is stopped. And I can't tell that on this study. And even on ultrasound, even though you can technically do it, again, the animal's on his back, he's stressed. So it kind of throws off trying to measure the amount of peristalsis. So I think this is a case where it may be semantics. I think when you're talking, and correct me if I'm wrong, you're going to say, could this be ileus? Because you think that this has like a functional ileus and the gut's just sort of a mess and it needs a little bit of supportive care. And I think it may be overstepping for me to say that I think this is gastroenterocolitis, because I need a biopsy, and have to see the inflammation, and maybe it's not. And so I think I could be wrong by saying that this is gastroenterocolitis. I think for me, the important thing is to say that this is not a GI obstruction. I don't see foreign material. I don't see any evidence of peritoneal effusion. I don't see evidence of pancreatitis. And regarding the GI tract, there's fluid in the colon, there's some stippled gas in the small intestine, and the stomach is empty, and the dog's vomiting and has diarrhea. So it probably has some inflamed gut. I just don't know the cause of it. So I think the thing to do is just to ensure that we're talking. Yeah. The caveat to that is if the dog just vomited, right before you took the rads, which you won't know on a telerads, So, and another point about the stomach is if you have an obstruction really high up in the small intestine, all that fluid, it actually just backs up into the stomach. And so you get a really big bag full of fluid in the stomach. And most of the small intestine is empty because the blockage is up high. But occasionally the dogs will throw up, and your sort of pop-off valve, being the stomach, doesn't look that distended, and so it can kind of trick you. So, okay. Anybody have any particular cases that they want to talk about? Is this still helpful? That case was not very sexy, but it's fine. It's helpful. We can talk about stuff. Oh boy. Okay, we got acute vomiting. 4-year-old whippet vomiting 24 hours. Oh, I told Graeme that I would look at that. Graeme, I'm going to get that lung. You just keep reminding me. We'll zoom in on it. One of the things that I'd consider was playing some reggae music during the downtime. So if anybody I was discouraged by a colleague from playing some 60 beats per minute reggae, but we'll see. You've got the answer. I'm not showing it yet. I'm not showing people what you said because you're right. Okay. Maybe this one's easy. Okay. So when we talk about the rad, you know what I mean? Let's not try to diagnose the problem. Maybe we'll do some Röntgen signs. Christy's diagnosing the problem. Okay. Never I thought the reggae would be fun because I was having a hard time shutting up during these pauses, and I just thought we need to fill it with a little bit of lively music. Okay. Let's not Let's do it. Caudal thorax. This is normal. I'm looking for pneumonia, and I'm looking for foreign bodies in the esophagus right here. I'm looking for pneumonia and foreign bodies. Bronchial patterns, forget it. Everybody looks like they got a bronchial pattern on an abdominal radiograph, so you got to chill out, okay? And I do this systematically, and my colleagues may not do this, but I do. I'm looking at the chest, and I'm looking at the chest, and that's all I'm looking at. Chest, 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 okay? Next, I go liver. That's fairly, it's not really parallel, but it's, at least perpendicular and sort of between it. So, and this is pointy. This is all liver, okay? And when you look in the liver, make sure the gall bag or the gallbladder doesn't have any gas in it. Make sure there's no mineral. Make sure this is nice and pointy so the liver is normal. There's the left kidney. That's acute, right? We can see it because it's surrounded by fat. So you can then say, well, the retroperitoneal serosal detail is fine. And this is the right kidney, and it's sort of tipped off at a different axis, okay? And that's also a normal kidney, okay? And then I do the urinary bladder, small and fluid opaque. And then I look down at the os penis. Urethra sits under the os penis, looking for little mineral. You'll never believe how many animals show up with urethral calculi, and there's no reported urinary signs. Okay, urinary bladder is fine. The next thing I do is the colon. I go, where's the colon? Gas, empty, empty, empty. I don't know. I lose it. I'm not gonna lie. I lose it. Okay, next thing I do is the stomach, because the small intestine I think is the hardest thing. So this is the stomach. Okay. It's got a mixture of gas and fluid. I would describe the stomach. The stomach is mildly distended with a combination of fluid, gas, and I would be more eloquent, but I'm just going to say, and then there's something in here. And then there's, I don't know, something over here. These are probably rugal folds. I kind of lose that thing that I thought was over here. So then I would just say, I don't know. There's something that's kind of odd here, right? All right. And then these things should catch your attention. These right here and these right here. Okay. So barbecue, July 4th in North America. There's a lot of corn. So these are corn cobs. So then when you see the corn cobs, you go, all right, well, fine. We got corn cobs. But where are the corn cobs? Because you don't want to have a negative explore. So you want to find out if they're in the colon. This one could still potentially be in the colon based on its relation to this sort of imaginary plane that the colon likes to sit in, right? This one's pretty ventral, okay? But the reason that this one is not in the colon is because you can convince yourself, hopefully, that it's associated with this big loop right here. And the colon should never, in the middle of the abdomen, make a turn with a caudal convex margin. It should never turn this way. Okay, so this loop, and I would bet this one and this one are in that same big old loop, but it doesn't matter. You don't have to, all you need to do is you need to go, okay, this is not normal. This is in a big old loop. Is this loop colon or small intestine? That's all I care about. And you go, I think this is small intestine because this is a weird turn for the colon. The colon does this. It comes out here, and then it loops around, and then it does this. And then there's this like cecum. Okay, so it doesn't do this. And then you go, okay, corn cob, this is way too big, and these are small, surgery. Next case. Don't make it any more complicated. Tell the surgeon, or if it's you, check that stomach, because I don't love that. It doesn't, I don't see the stippling or the regular gas and soft tissue pattern of a corn cob, but this is telling me that maybe there's something else in there. Any questions on that one? I want to get that lung for Graeme. Oh, there we go. Where was it? Boom. Okay, Graeme. I'm going to find the next case, but you were talking about the lung. Which lung, which view rather, did you want me to zoom in on? This one? And I would caution you with zooming in too far, too often, and not because like, oh, I look at these all day and I don't need to, but you'll start to hallucinate and you'll see stuff, and then you'll lose the forest for the trees, and you'll kind of get overwhelmed and you'll start making up nodules and stuff. So the over zoom, you got to be careful. So I don't know if maybe Graham's asleep. I think it's like midnight in Scotland. Maybe he's in England, but he's Scottish. But if we don't have Graeme, I'm going to move on. I think what I was looking at on this view is right here. You can use sort of internal controls. This little nugget of lung doesn't look as opaque as this nugget of lung, and these sides look asymmetric. Maybe you're going, wow, that's subtle. I don't know if I would do that. DV view, DV view. Lateral view, you go, boy, that looks like something. Is that expiratory? Is that edema? Dog's tachypnic. I got a big heart, probably edema. DV view. Okay, so one of the things that I did during my residency is a GI obstruction study. And as a result, I've got 100 cases of patients that either have an obstruction or not, and it's been confirmed through surgery or ultrasound. I think maybe I brought this up. And so I know for a fact, we know for a fact what happened to these patients. And let's see if I can get the one downside is that they are in JPEG format, which prevents you from windowing and leveling, but we optimized them for viewing. So you don't need to window and level. All of the animals that came in for this study were acutely vomiting. Okay, all acutely vomiting. You got a right lateral, you got a left lateral, you got a VD view, and another VD view. Okay, so I'm going to chill and I'm going to give you a couple of minutes and you can decide if you think the animal's obstructed or not. If you're not convinced, maybe what's the test that you would do? And the options would be do an ultrasound now, which would indicate you're pretty concerned. 8 to 12 hours of fasting, supportive care, and repeat abdominal radiography, which would indicate maybe some level of concern, or do nothing, or follow up if you haven't improved in 24 hours. There does appear to be different populations of bowel would recommend an abdominal ultrasound. So Dr. Miller is expressing some level of concern. Okay, caudal thorax, maybe a little bit of fluid in the esophagus, that's fine. You can have a little bit of fluid, transient swallowing, maybe a little bit of reflux. Should we freak out about esophagitis? Probably not, because we don't have enough information. We're looking for pneumonia down here. I don't have a ton of chest, but I don't see it. Let's talk about the liver. Okay, gastric axis is tipped a little cranial. I don't know. Sometimes the left lateral view gives you a little bit more liver. Spleen here, kidney. There's the caudal pole of one kidney. Right kidney, I can't really see. The stomach, mildly distended, mostly with gas, but there's maybe something here. A little bit of an opacity here. Okay, urinary bladder fluid, opaque, small, mineral opaque calculi, no. VD view. There's the splenic head, little triangle of love. Here's the stomach right here. Okay. Hip joints. Very nice. So for the GI tract, what we want to do is we want to try to get like a global idea. And what you're trying to do is take it all in by going, what's the stomach doing and what's the small intestine doing? I'm not really that concerned with the colon unless you're like, colonic torsion. But colonic torsions, these things are huge. So this is colon coming through here, but I lose it. I don't think that's it. Could be it, but I don't know. So the colon should come through here, right? And so it should be in here. So once you can identify the colon, I'm not sure that's it. It goes through there. It's supposed to be around here. So this is the shitty test because I'm having a hard time seeing the colon. So if you panicked, you could do a pneumoclonogram. For those you don't want to get a nurse, you want to get an intern. So you do the pneumoclonogram, and then you look and then it'll be much more obvious what's colon or not. But this particular loop right here looks too big, right? This is too big. This structure right here. So that one's a little bit too big. This is a bit of an odd, kind of coming together of it doesn't look entirely plicated like a linear foreign body. But this is the loop that should give you pause right here. And I would caution you that this could potentially be in the colon. It's it's concerning for small intestine here, right? But the colon can do some weird sort of loop-de-loop things, and there's some redundancy that can happen. And so maybe you go, this is colon. Okay. If this was in the right abdomen, probably not, right? Because the descending colon pops out and it goes around here and then it comes this way, right? So if this was in the right caudal abdomen, you could say for sure not colon. It shouldn't be this far descending. Sorry. If it was in the colon and it's in the right side of the patient, it should be in the ileocolic junction, which stops at L25. So if there's something back here, it's not going to likely be in the colon. So this structure is over here. So this is still potentially, based on these orthogonal views, you could still say maybe this is in the descending colon. So this is a great case for a pneumocolonogram. And for those of you that expressed concern without the pneumocolonogram, you're spot on, because this dog was obstructed. And this is a foreign body right here. And there's some mineral foreign material here. And these loops are a little bit too big. But it's, I think, a bit of a difficult case because you don't get that classic really big two populations, because I don't know if this is small intestine. I mean, this is going this way and this is going this way. So one of these is probably small intestine, though the other one could still be colon. So your classic obstruction pattern is here, but it's not like super duper obvious. And so as a result, I think the pneumocolonogram could be really good. Okay, same thing, right? All these cases, acute vomiting, and we're worried about obstruction or not. Good question. Is the gastric wall thickened? Okay. So cool. Well, I mean, I think the fact that you guys are committing to various things is just going to do nothing but help you, which is why we're here. So, not to beat a dead horse, I'll skip. Maybe you tell me. I mean, I can keep going through. I guess it probably doesn't do any good unless to highlight all the different organ systems each time. You've seen how I go through it. I'll tell you if they're not normal. There's a lot of falciform fat, which makes the liver here look small, but it's not. So liver is fine. They're the kidneys stacked on one another, and they're fine. Urinary bladder, I would describe as moderately fluid-filled. You can look for the intra-abdominal urethra to determine if it's distended. You want to make sure there's no mineral. You can see mineral urethral plugs and so on. Okay, so caudal thorax. I look at the caudal thorax. This is the aorta. That's the caudal vena cava. These are pulmonary blood vessels. Cats, not as often. You're going to see pneumonia. You can see pleural fluid. You can see cardiomegaly, pulmonary mets. So look at that caudal thorax. Here's the liver. Liver's right here. It's fine. Big old falciform fat, well fleshed. Gatto. And so this thing is going to dump fat in the falciform, which is an extra peritoneal structure. Don't forget. And it's going to make the liver look small. This liver's fine. Kidney, normal. Left kidney, normal. Right kidney, normal. Spleen, there's a splenic head. The splenic body is probably draped over here. So the spleen, you're right, not a splenic problem. Okay. So you will sometimes see splenomegaly. It just fills up this left quadrant, but you'll also see the splenic tail ventrally. Colon, formed feces. So it's acute. This is where we can use that acute thing. So formed feces and gas. Maybe this is the ascending coming around. Maybe this is the ascending. But I'll be honest, I kind of lose it. I just know that it should be over there, but I'm not sure. I know that this is colon. I know that this is colon. And I think I can hallucinate that this is the dorsal wall and it kind of follows this. But I don't want you to think that I sit at these rads and I go, okay, boom, where does this go? And then I follow it. I don't do that. I go, here's colon. So then what's that? Here's colon. So then what is that? And I go, okay, 765 colon. I kind of lose the colon down here. The colon has formed feces. The colon comes around here, kind of does a loop-de-loop. I lose it. It may be this. I'm not sure. But that's the stomach. That's a big old stomach. And it's mostly full of fluid. And this sort of snowman or, undulating appearance is from peristalsis. So to this question about like a functional gastric atony, just a big flaccid bag of fluid, I'm not convinced, because these are peristaltic and this is a crunch. This thing's like, and so I think this degree of fluid with this degree of crunch should make you think it's trying to push something through. If you ever see fluid, especially if it's anything approaching this volume of fluid in a cat, game on. You got to start looking. You got to look for an obstruction. And again, if the stomach is this distended, you should start thinking proximal, right? This is the pop-off valve. If you're going to convince yourself that the stomach is really this full of fluid, you got to think that there's some sort of obstruction. Foreign body, intussusception, tumor, an annular carcinoma will crunch down. Annular carcinoma, I'm going on these tangents. The annular carcinoma tends to cause chronic partials, and so you tend to have less peristalsis. It just kind of goes, So big old bag of fluid, big old stomach. This is all stomach. This whole thing is stomach. And this is a gas cap sitting on a fluid, a bunch of fluid. So when you see a stomach like that full of fluid, you think proximal obstruction. Where's the proximal obstruction? Because all the fluid is dumping upstream into the stomach. Okay. So this small intestine looks pretty empty down here. But this thing, I didn't see this, but I saw this. Okay. So this thing, you go, well, could this be in the colon? Could this be in the colon? Could this be the ascending colon? So then you go 7, 6, 5, 5, maybe 7, 6, 5, 5, 6, 5, 7, 6, 5. So you just start cruising through here and you go, well, what's that? And it's right next to the colon. And then you could stare at this long enough and you go, there's something that's doing this. And then when you look over here, you go, there's something doing this. Okay, don't make it any more complicated. This is an obstruction. You don't need to. I make it sound easy, but you're not going to get sued if you go, this cat's got a ton of fluid, and there's this thing that when does the colon go up and down this way? And you know that this is colon. You know it, and you're like, well, what is that thing? Well, if that thing's in the colon, the only way that this thing could be in the colon, based on this view, is if it was in the ascending colon, and that's a long shot. So if this was in the ascending colon, ileocolon junction area, it should be over here, but it's not. It's right here. Obstruction. Okay. How do I know the stomach on the lateral views? The snowman Kong toy is in the stomach and not a separate structure. So let's play. Let's play devil's advocate. So I would describe this as the stomach is severely distended with fluid and a small amount of gas. That's it. I wouldn't talk, if you were a new client and you wanted me to I think when I've worked with clients over and over and over, you build in that goodwill and they know what you're saying and they've read your reports. And so I don't need to go into a lot of detail to get the point across, which is the stomach is abnormal. So I wouldn't talk about Kong toys and peristalsis and all that. They would just go, okay, we trust Peter. We hope he's right. We think he's right. We see what he's describing and we kind of trust it and we're going to go for it. So how do I know this is the stomach and not another structure? Graeme, if you can convince yourself that these three are related in the snowman Kong toy, okay, this structure, if you can convince yourself that this has gas and this has gas. So if these three are related and two of the three snowmen have gas, then you go, okay, this structure more than likely has something to do with the GI tract because it has gas. Maybe I go, this is a gigantic gallbladder and he's got emphysematous cholecystitis or whatever. But what's interesting about the gas is it's very cute and circular. It's very round. It's not this weird angular thing like that. It's very round. And so when you have angry gas that's in an angry gallbladder or emphysematous cystitis or emphysematous cholecystitis or a pneumoperitoneum, they don't look cute and round like that. They look fragmented and angular and just so this structure, you got to go, okay, it's in the cranial and ventral abdomen. What lives up there? Well, the liver lives up there, but that liver looks pretty good. Well, the spleen lives up there, but then there's this gas structure that's associated with it. And I don't think there's going to be, you can have an emphysematous splenitis, but boy, that's fairly rare. So I think what you got to do is you just got to go, this structure is the stomach. I mean, the margin is right here. It goes around, goes around, goes around, goes around like this, and it goes around like that. The other thing that you could do, I think that would be very helpful, is you get a left lateral view. And if you get a left lateral view, you probably get the benefit of the doubt that a lot of this gas cap starts to dump into these. Okay. And so a lot of times we'll get, not a lot of times, but sometimes we'll get referrals for, there's a mass in the pylorus, there's a mass in the cranial abdomen. And yeah, that looks like a mass. But the reason you chill out is because like, well, that's part of the stomach and it's full of fluid, and maybe it's thick walled, maybe not, but it's at least full of fluid. And so I don't see why you wouldn't make it standard to do lateral, left lateral, right lateral, and a VD view on the abdomen in every case. Because what will happen is over time, when you start to see things like this, and then the left lateral pops up, you go, oh, and then you see this 2 or 3 times, and then you'll be like, okay, that's just the stomach. Okay, let's do last one. My wife is going to kill me. I got a 7-year-old and a 5-year-old, and I told her that I was going to do this thing where I taught other veterinarians for free after work. She's pretty pumped. So I can give you her I can send you the address, and you can you can send her, candy. I'm just kidding. 3 views. Acute vomiting. This is a dog. It's a male dog. He's probably 3. He's acutely vomiting. Same thing. We know if he's obstructed or not. The goal for you is to decide if he's obstructed or not. But the next layer, if you are uncertain, is to practice that clinical sort of, what would I do? And would I do what Peter would recommend in terms of any follow-up diagnostics? Okay. Yeah, you guys are all welcome. I think I don't want you to, now you're going to make me feel badly. I was just joking. You don't know me well enough, but most of the things I say are sarcastic. I work alone, and I've got a small team, but I talk to a computer all day, and I thought there's got to be a way to connect with people. And the big question for me was, how many veterinarians still care? How many want to learn, work on their craft, improve their diagnostic imaging skills, help more animals, help more people? There's a lot of negativity with private equity stuff and mental health stuff and burnout and debt and all that. But I've been, there's only 24 people on right now, but some of you probably should be asleep. Some of you keep coming back, and I'm having fun, and I feel like we're all learning, and I get to figure out what questions you guys have, so it helps me write better reports. And so I'm going to just kind of keep doing it. All right, liver looks small, kidney okay, stacking bowel loops, difficult to visualize the whole colon, concerned about an obstruction. Okay, I would try supportive care and recheck RADS. Okay. Let me see if I still have, I had a scale that I can share with you. Maybe I'll send it in an email. It's a modified Likert scale that we use for the study that can allow you, at least in your mind, to go, what do I think this patient is in terms of the scale? And the scale is, definitely obstructed, probably obstructed, not really sure, probably not obstructed, and definitely not obstructed. And so when I was starting out, I would try to figure out, where do I think the animal is on this sort of scale? Because then that would help me with my next step, my next diagnostic imaging step. So if I convinced myself definitively that the animal was obstructed, and I felt very confident, you could send it straight to surgery. If you felt that it was probably obstructed, I would try to get the ultrasound today. If you felt like it was probably not obstructed, you could do things like fast, 12 hours, supportive care, recheck RADS. If you felt like it was definitely not obstructed, you could just say, look, I don't want to see you again unless you're not better, in 24 hours. So, okay, so there's a soft tissue opacity between the spleen, the stomach. Yeah, so a couple of things. Here we go. On the lateral, Doc Allen wants to know, is there soft tissue opacity between the stomach and the between stomach? Is it the spleen? So little bit of rotation right here, a lot of back fat, left kidney right here. She may be talking, there's this thing right here. Okay, so the splenic head is like doing this. So the X-ray beam hits it, and so you get this like little, it's like a little triangle. It looks like that. I don't know if we can get this. Boom. Okay, so when you fire off the red, you're getting the splenic head. So the splenic tail is right here. The body goes up here, but you kind of lose it, and then the splenic tail is this structure right there. So right here. Okay, so when the animal's on its side, the X-ray beam goes and it hits this thing. And of course, it's right next to the left kidney. So left kidney, splenic head, and the splenic tail kind of goes over here and I lose it. I'm not going to tell you that I see it, but I know that it's not displacing things. It doesn't look round. So one kidney, here's the other kidney. This thing is the splenic head. Okay, I do think the liver is skimpy. However, the gastric axis is parallel to the ribs, and so we sort of have to say, well, I think it could be normal for this particular animal. Caudal thorax is fine. The liver is on the lower limits for size, but I would describe this as the liver is somewhat small, but given that the gastric axis remains parallel to the ribs, it's probably fine for this patient. Next thing I do is the kidneys, which we described. Left kidney, right kidney, they overlap or summate right there. There's the left kidney. It's normal. There's the right kidney right in here. You can measure the length of these relative to L2. And a dog, they should be 2.5 to 3.5. I find that those aren't always incredibly accurate, but that can give you an objective measurement. So you measure the length and you go 1, 2, and then you measure the length of L2. Cats, let's see. Cats, it's like, depends on their neutered status. Intact male cats, it can go up to like 3.2, but I think 1.9. Usually 2 to 2.6, 1.9 to 2.6. Urinary bladder, small and fluid opaque. Colon, I kind of lose it. I don't know. That could be it for sure. This could be it for sure. I kind of lose it. But what's not it? These things. Not it. Stomach right here. Okay. Left lateral view. Pylorus gas filled. This is probably the pylorus comes up and then it dumps into the duodenum like that. Okay, so there was a study out of Florida that I loved. It said if you put a dog in left lateral view first for the abdomen and then took the subsequent images, it increased the chances that the duodenum would fill with gas. And that's great because gas in the GI tract is a great, it can outline things and really help you assess different structures. And so maybe start with the left lateral view. Graeme asked for any landmarks for the cranial limit of the colon. Yeah, I mean, on ultrasound, what you'd find is that it shouldn't. Some of the caveats to this is if you have a redundant colon, sometimes you can have a lot of excess colon. Sometimes cats will have a short colon syndrome. There's not a lot reported on it, but sometimes it's with chronic GI disease, the colon. You run up the colon and the ICJ is like right here and you're like, well, that's not normal. But I think in the normal patient, the cranial limits, it kind of butts up against the stomach. You shouldn't see it coming way up here. So the colon should come up here and it should kind of arc around here. And there's a ligament that anchors this, I believe, near the duodenum. Somebody can maybe help me find that. There's a ligament, duodenocolic ligament. I'm going to throw that out there. Don't write that down. We can edit that out after. I think there's a duodenocolic ligament that anchors this ICJ here, which is why you damn near see it in this position all the time. L25 right of midline. Okay, so this usually does this arcing thing. So this could be colon. And we feel pretty convinced that the stomach, we feel pretty convinced that this is duodenum. So that could be colon, but that could also be small intestine. So these stacking structures, don't freak out about the stacking, okay? So small intestine, there's a collection of loops in the right caudal abdomen that are mildly distended with gas and a small amount of ill-defined soft tissue. These loops are mildly pathologically distended, but not severely distended. The remainder of the small intestine is either empty or only mildly gas-filled. These distended loops are normal there's some mild stacking, but there's no plication or corrugation. In this particular case, I would consider this a difficult case because I think a lot of you are going to see this and you're going to go, oh boy, we got to cut the dog. But some of the things that I want you to take away from this are that for me, this is a patient that I would not characterize as a definitely obstructed. So I don't want you to look at this in your clinic and go, this dog is definitely obstructed. And the reason is because these are mostly filled with gas and only mildly distended. The stomach is pretty empty. So usually with the GI obstruction, especially if it's been over 24 hours, I think I've said this, but it fills with fluid upstream from the obstruction. So you do get this mixture of fluid and gas, and not just this gas. So only mildly distended with gas. The stomach is pretty empty. Gentle turns. For me, this would be a one where I would say, I think you need to ultrasound the dog right now. So I think you could say, let's ultrasound it and make sure there's not an obstruction. Looks like I missed Amelia's ventrally between the spleen and the stomach. Ventrally between the spleen and the stomach. Here. That's probably a loop of bowel. Because it see how it looks tubular? That's why I would, that's probably a segment of bowel. Yeah. Is this loop normal in size? This loop is not that concerning. This loop to me looks similar in size to this. And so you're going to say, well, then is it fluid filled? I think this is a segment of intestine. It maybe have a little bit of fluid in it. It may have a thick wall. I'm not that completely bothered by it. But yeah, we're going to do every Monday, Tara, every Monday until there is nobody that shows up. And boot camps and stuff, I've got your emails, and I'm not going to spam you, but I'll if I decide to really invest a ton of time and do like a boot camp, maybe we can figure out how to do that and then structure it, and then maybe we can sort of group people based on comfort level and experience, and therefore we can sort of dial it up or turn it down a little bit, and we can just go to nuts on cases so that you can feel better. So anyway, so that I can send you when I'm going to do it. But I'm going to do it next Monday, same time. We've got Thanksgiving holiday coming up, so I may switch it to like a Wednesday at some point, but it's just going to be a one-time switch. I'll give you a heads up, and then we'll revert back to Mondays. So anyway, all right, guys, have a good week. I'll talk to you soon. Ciao.